Hi friends, in today's ECG basics videos, I will talk about right bundle branch block. First is a disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. The ECG diagnostic criteria for right bundle branch block is QRS duration more than 120 milliseconds, RSR- pattern in chest leads V1 to V3, or we can say M-shaped QRS complexes, wide slurred S wave in lateral leads, that is lead 1, AVL, V5 and V6. So in limb leads, in lead 1 we get wide slurred S wave. During the right bundle branch block, the right ventricle is not directly activated by impulse traveling through the right bundle branch. In chest leads V1 we get RSR- pattern and its duration is usually more than 120 milliseconds, or we can say more than 3 small boxes. And we get T wave or ST depression, T wave inversion and ST depression, and it is common in V1 to V3 in right bundle branch block. In left sided lead like V6 we get slurred S wave, wide slurred S wave. In V6 the S wave should be greater duration than the R wave or greater than 40 milliseconds in V1 and V6. So in this ECG we can see that we get RSR- pattern in V1 with appropriate discordant T wave changes. The V6 we get wide slurred S wave in V6. Appropriate discordant means there should be ST depression or T wave inversion in the right precordial leads, that is V1 to V3. As we get RSR- pattern, that is first positive deflection, that is R, then we get S negative deflection, then R dash, that is positive deflection. Therefore there after positive deflection there should be negative deflection of the T wave or ST depression should be there. This is called discordance, means initial positive deflection, then we get negative deflection of the T wave or the ST depression. If we get deflection on the same side, that is RSR, if R dash is upward, is upright, and we get T wave upright or ST elevation, then this will not be a discordance. This will be a concordant, and it will suggest us ischemia. So discordant T wave, that is T wave inversions, and ST depression, they are very common in right bundle branch block in chest lead V1 to V3. Coming to electrophysiology, in normal cardiac conduction, the impulses travel equally down in the left and right bundle, with the septum activated from left to right and formation of small Q waves in the lateral leads. In right bundle branch block, the left ventricular is activated normally, and thus early part of the QRS complexes, they correlate to the septal depolarization. And their correlation to septal depolarization is unchanged. There is delayed activation of the right ventricle as depolarization originates from the left ventricle across the septum, and this produces a secondary R wave, that is R dash, in the precordial lead and wide slurred S wave in the lateral leads. Normal activation of the left ventricle means cardiac axis remain normal in isolated right bundle branch block. A sequence of conduction in right bundle branch block is the left ventricle activation occurs by the left bundle, that is black arrow as shown, it is normal, and then septal depolarization, that is yellow arrow, is thus unaffected. It produces normal early QRS complexes. Activation of the right ventricle originates across the septum. The resultant depolarization vector, that is the red arrow, it shows a delayed R wave in lead V1 to V3 and S wave in the lateral leads. In this ECG, if we see the QRS morphology in V1, QRS morphology in V1, it is RSR- pattern. Sometimes Rather than RSR dash pattern in V1, there may be broad monophasic R wave or QR complex also be seen. So typical RSR dash pattern or M-shaped pattern in V1 is mostly seen, but at time we can get monophasic R wave or QR complex in V1. We get wide slurred S wave in lead V1 and V6. The appropriate discordance means uh, abnormal depolarization should be followed by abnormal repolarization, which appears discordant to the preceding QRS complex. I have already discussed in my previous slides. In right bundle branch block, discordance means this should manifest as ST depression and or T wave inversion in lead V1 and V3 after RSR dash complexes. The causes of the right ventral branch block are right ventricular hypertrophy or pulmonary embolus, ischemic heart disease, rheumatic heart disease, congenital heart disease like atrial septal defect, myocarditis, cardiomyopathy, Lenègre-Lev disease, that is primary degenerative disease of the conductive system, and there is increasing literature that suggests that the context of the chest pain, a new right ventral branch block is highly concerned for OMA and a potential indication for immediate reperfusion therapy. The right bundle branch block is right bundle branch is supplied by the left anterior descending perforators in most patient population, and thus occlusion of the branch may manifest as a new right bundle branch block plus minus left anterior fascicular block. The right bundle branch block with left anterior fascicular block, here we can see broad QRS more than 120 milliseconds. Here we can note that prominent delayed RV conduction. It manifests as a tall broad R wave, that is R dash, best seen in V1, widened S wave in the best appreciated in lead 1, and there is appropriate discordance in the right precordial leads with T wave inversion. Isolated RBB is also seen, typically RSR dash pattern in V1 to V2, widened S wave. Again, it is seen in lateral leads, especially V4 to V6, and appropriate discordance in lead V1 and V2. Right bundle branch block with left anterior fascicular block can be seen in patient with chest pain. And here we can see RSR dash pattern in V1 and V3, V1 to V3, and slurred S wave in lateral leads. There is concordant ST changes, best seen in V2 and hyperacute T wave inferiorly. This patient was found to have 99% proximal LAD occlusion. Here we can see that there is the RSR dash pattern, but in V1 in V2 we can see ST segment changes, that is ST elevation is there, hyperacute T waves are there after RSR pattern. So just see in V2 we get RSR pattern, or we can see there is concordant ST segment changes which are seen in V2, and we get hyperacute T waves inferiorly. So here we can see hyperacute T waves inferiorly. Both T wave and this S wave are towards the same direction. This is the concordant, which is suggestive of left anterior descending artery occlusion. We get incomplete RBBs when RSR dash pattern or QRS complexes is less than 120 millisecond. It is a normal variant and it is commonly seen in children, and it is of no clinical significance. Differential diagnosis of RBB is RSR dash pattern of V1 to V3. It can be seen or can be caused by Brugada syndrome, an ECG pattern associated with malignant ventricular arrhythmias. Dr. Jonas Salk has said, "Hope lies in dreams, in imagination, and in the courage of those who dare to make dreams into reality." With this, I conclude my today's topic. Thank you. Keep learning.